Hello, everybody. My name is Tony Young. I am the CEO and president of Rise San Diego. Thank you for being a part of today's discussion. I'm just really impressed by the panel that we have here. They have all kinds of experience and insight, so much so that I think this time it'll probably be better for them to explain what they do and what they know. I think that's how we'll start off today. But we're going to have a conversation. I think it's a really important conversation about COVID-19 and the vaccine that everyone is hearing about. Different vaccines are actually happening, some of the processes that are in place and some of the prospects that might happen, and maybe some background of the science behind it and how it relates to the African American community, the Black community, who has had a very, uh, I would say, complicated relationship with the medical community. So we're very excited about that. And again, welcome to Rise Now. With that, we want to go over a little bit about who Rise is. Rise is an organization that really focuses on the urban community, and we focus on issues specifically related to leadership. We support nonprofits and for-profits in their development. And then we have these types of events when it comes to civic engagement and trying to bring real information to the community. And we're going to continue to do that. There's some new ideas that are happening, and we'll let you know as we move forward, but that is who we are. We give you a little bit of community guidelines. So just so you know, all attendees are muted. So the people who are, as you watch this discussion, you won't be able to vocally participate, but we have a Q&A box that we use for questions. And we also have a box that you can actually provide, just your comments about the discussion. So it's kind of a back and forth, and everybody can see what you're saying in the comment box, and then the moderator will use that to actually share some of your questions. So we have as I said, a great panel. And what I'm going to do is I'm going to allow our amazing moderator, someone who represents our community. She is really a joy and a jewel for the community of San Diego, Dr. Roxanne Kimani of Kimani Catalyst Consulting, and who is also a RISE faculty member, who will introduce our panel, allow the panel to introduce themselves and guide us on this discussion. Dr. Roxanne?
Yes, thank you, Tony. Thank you to our panelists and to our audience for listening in, both on Zoom and on Facebook. Black people represent just 13% of the country's population, but nearly 30% of total coronavirus cases and 16% of total deaths. We are dying at higher rates than any other group in this country. But despite these numbers, some of us are still hesitant to receive the vaccine, a result of this country's long history of medical racism and abuse in our communities. When it comes to the effectiveness of this vaccine, the statistics show that it's been overwhelmingly positive. Two of the top vaccines from Pfizer and Moderna have proven to be more than 94% effective in preventing symptoms of COVID-19. And the CDC judges that the vaccines are working and to be a very low risk. Within the Black community, however, there is still a genuine mistrust of the US medical establishment. Black people have been traumatized by a betrayal of the system forever, for generations. And so people have believed in the systems, and systems have failed them. The healthcare system has failed them. Black Americans are suffering higher rates of severe disease and death during this pandemic, and they are receiving COVID vaccines at a dramatically lower rate than white Americans. So how can we encourage more people in our Black communities to get the shot? In a moment, I'm going to turn to our panel to help us understand how the vaccines work, why it is important for us to get the shot, and to help dispel some of these myths, and to support our community's access to valuable information. I'd like to ask our panelists to introduce themselves. Dr. Jeanette Aldous.
Hi, thank you, Dr. Kimani. My name is Nettie or Jeanette Aldous. I'm an infectious disease physician. That means that I am both a primary care internal medicine doctor and I specialize in infections. And so I treat HIV and tuberculosis. I specialize in vaccines. And for the last year, I've been doing a lot of work with COVID response. And I currently also serve on the COVID clinical advisory committee for the county. So I've been very closely involved in that effort. I'm originally from Philadelphia and I have been in San Diego since 1994.
Thank you. Dr. Sudan Aflalo. Sudan.
Thank you so much. Yes, Susanna Flalo, I'm the medical director over at the Alliance Health Clinic, which serves the refugee population. I also worked at Kaiser Permanente as a family physician for over 23 years. And now I do quite a bit of work in the community, including a monthly health fair, along with several task force and things related to COVID testing in the community with SDSU's NIH grant, Scripps grant, and also multicultural. So I'm out in the community doing COVID testing and now COVID vaccine.
Thank you. Dr. Sayon.
Hi, everyone. Pleasure to meet some of you or see some of you again. Thank you, Dr. Kimani. I'm a medical consultant. I'm a public health doctor for the County of San Diego Health Department, and I am a medical subject matter expert in the Emergency Operations Center with multiple different roles. Happy to serve.
Thank you. Ms. Keisha Robinson.
Hi, my name is Keisha Robinson. I am an Associate Director of Clinical Research at Illumina, where we specialize in whole genome sequencing. I train physicians and other clinicians how to do genetic or genomic clinical research studies. I also serve on the UCSD COVID Advisory Committee and the Scripps Community Advisory Board. I am also a survivor of COVID-19.
Thank you. Ms. Branique Madden-Bowman.
Hello. So I actually work with the county. I'm one of the many people you might see if you go and get tested or the vaccine. We're one of the first people that you're going to check in with. So I'm one of those people that you see.
Thank you. Okay, so let's get
Dr.
some
Kimani,
info.
I forgot to say where I work. I probably should have mentioned that. So I work for San Ysidro Health, and so I see patients at the King Chavez Health Center in Southeast, as well as in Chula Vista and in San Ysidro.
Thank you. So let's get some information from our audience with the first poll question. Are you planning to get the COVID-19 vaccine? This poll is only available for our Zoom participants, but I'm hoping for those of you on Facebook, just write down what answer you think you have right now. And our panelists, unfortunately, you can't participate, but I would imagine you all have already received it. While we're waiting for our audience to complete that and for the answers to come up, let me first ask the question of you, Dr. Jeanette. Can you explain how vaccines work in simple terms for people who maybe don't understand it, such as myself?
Yeah, sure. And I'm going to try to give a brief answer, and we can always do follow-up questions. But the way that vaccines work, to be basic about it, is that vaccines teach your body how to protect itself when the real challenge comes along. So if I get a vaccine for the flu, the point of that vaccine is to train my body so that when the real flu comes, I have my soldiers and my defense system ready to fight it. So what does that mean? That means that almost all vaccines work by finding some way to give my body a little piece of that either bacteria or virus so that my immune system can mount a response. And so that's called your immune response. And when you have an immune response, then the next time your body is presented with a piece of that virus or bacteria, your immune response is ready to go. So that's how all vaccines work. Now they have slightly different technologies behind them, right? So some of them might just take a piece of that bacteria or virus and basically just chop it up and give it to you, right? Some of them might take a little bit of that virus and make it really weak and give you a little bit that way. The newer vaccines that we have now are based on actually years of research and older technology that are now being applied to COVID. And what they do is they actually get your body to make that little piece of the virus, and then your body produces the immune response. But in almost all cases, what's happening is that your body's being shown a little piece of that infection, and then your body learns to produce a response to it called an immune response. Sometimes people talk about antibodies or things like that. Those are all your immune response. And then when the real virus comes to you, your body's ready to fight it off and you don't get sick. That's the basics of vaccines. And I'm happy to have any other doctors want to chime in on that answer.
Dr. Aflalo or Dr. Sayon?
I
That was
think,
perfect. Good.
yeah. No, I
There's some-
was just going to say, she's explained it well enough for people. So if there's additional questions after what she's explained, we can certainly expand on that.
And certainly the newer vaccines, people have questions about those. We could get into that later.
Absolutely. Thank you. Thank you. So why is the Black community considered to be a higher risk when it comes to COVID? And I'll ask that of you, Dr. Aflalo.
Sure, thank you. I think the most important thing is that number one, we do have more underlying medical conditions than the general population, most minority communities. So your chronic diseases like hypertension, diabetes, heart disease, lung disease, obesity. And so these are some of the health conditions that put us at more risk. So our body's kind of not at its ultimate. And so the virus, when it attacks our body, it tends to just really, it has a system there that is already slightly at risk. And so it tends to get involved, and we end up having a bad outcome related to the virus. So some people get better, just have mild symptoms and resolve, but some people with underlying medical conditions actually do worse, get very sick, can land up in the hospital and even in the ICU. And unfortunately, we are at the higher end of death rates too. So it just tends to affect our population and other minority populations in such a more serious way.
Thank you. I want to turn to you, Keisha, kind of leaning on that as a survivor of COVID. Can you share a bit about what your experience was going through it?
Sure. So I didn't necessarily experience all of the symptoms that you hear a lot, like what people say you'll lose your sense of taste or smell, or you may have aches or headaches. I was virtually asymptomatic, to be honest. And I actually had already had a cold. So I knew that beforehand, just because I had a cold sore, which is usually my indicator. But one thing that was definite, and I'm really, just kind of in tune with my body, is I was exhausted. Like, I mean, completely zapped, almost like a narcoleptic. I could not keep my head up for 2 days straight. And so but I had just finished traveling. I had been in 3 different time zones. I didn't really sleep a lot. So I kind of attributed to that, but something still felt a little off. So that was one thing. I felt a little achy, but it was like very, very minor. So again, nothing really major. At the time, I was lifting a bunch of luggage, probably should have lifted one bag at a time. Again, I kind of wrote it off. But then the one thing that finally caught my attention is that I had like this chest pain. I shouldn't say pain. It wasn't pain, but it was discomfort. I called it like my little elf on the shelf. It just felt like something was just constantly sitting on my chest. So I would do things like try to take a deep breath. And I realized that it was labored. Like it didn't feel as it normally did. And I kept that chest discomfort probably for about the whole entire time that I was quarantining, and maybe for about another week and a half to almost 2 weeks afterwards, I still felt that. But I think and overall there was a certain malaise too. So I was tired, a lot more tired than I normally was in general. So that was something too. But some of those things are just very easy to write off. And part of me second guessed a lot of it because I had already had a negative test. So I had traveled and I had taken a test like within 3 days. And I'm like, okay, well, let me just take another one within the 6 to 7 day range to make sure I'm good and to allow my body some time just in case. And sure enough, that second test came back positive.
Thank you. With so many people testing positive and working their way through the virus as Keisha, once they've had it, do they need the vaccine? Dr. Sayon?
Sorry. Yes, the recommendation is that you still get the vaccine, but the CDC says a few things, right? You can and you should definitely wait until you're no longer infectious. And then because of limited supply of vaccine, you can choose to delay when you get that vaccine. Meaning, we know that after COVID infection, like Keisha, I'm going to use you as an example since you volunteered yourself, that she has immunity. We just don't know exactly how long that immunity lasts and how it varies by people. We have a sense that, some people who are more severely sick from COVID may have longer lasting immunity, but we're still waiting on some of that data. So they recommend, you may not need it right now, and you can choose to delay it later. There is some data saying that, if you get it very close to when you had COVID, if you get the vaccine, you may experience a little bit worse in terms of side effects. None of the severe life-threatening, none of that stuff, but you may have kind of worse side effects. So that may be another reason to delay. But either way is okay, as long as you are not infectious, and which is usually 10 days for most people.
I want to just piggyback on that because I agree, but also you may hear people recommend that you wait. And that's a reasonable recommendation, not because of vaccine supply, but your own individual doctor. So sometimes I give my expert opinion to my patient and I might say, you really don't need this vaccine for probably 3 months at least. And so I'm happy to give it to you. I just don't think you need it. And you probably have good reasons to wait until you've recovered. Make sure you get a good response to the vaccine for future protection. Some patients might not want to have I try not to call them vaccine side effects because they're effects. When you get a vaccine, it produces an immune response, which is good. That's what we want. And immune response feels something. You might feel body aches or fever, and that's normal. But if anyone who's had a vaccine will tell you that. But if you've had COVID before, you might have more of those symptoms. So I just want to make sure people know that if their provider or their specialist recommends that they wait, they don't have to wait, but that recommendation is reasonable to say, why don't you just give it time? You don't need it.
I know for me, the county definitely suggested that I waited. And I knew on my own, like once I had a positive diagnosis, I was like, okay, well, let's see how long it takes for these antibodies to, present. And so I actually retested. I took the antigen test just to confirm that I actually had antibodies. So for me right now, it would be pointless to take an RNA induced vaccine when I have, unfortunately, natural antibodies because I actually had a positive diagnosis. So I'm kind of just waiting it out, honestly, in the interim. But I did get advised by the county, like I wouldn't even bother with you taking a vaccine at this point. And some of that, and there was no real reasoning. I think some of it could be because supply and demand, but it just honestly doesn't necessarily make sense at this point unless some people need to do that for their own comfort. Me personally, I don't see the need to do it at this point until I'm at least at the 3-4 month mark, as Dr. Aldis said.
Okay, thank you. I wanted, talking about waiting on getting the vaccine, we have a question from our audience and some questions that I've also heard just out in the community. When you have folks who have sickle cell disease or something else that can impact their immune system or other parts of their body, what should they do? Is this something that they should still want to go get right away?
Yeah, I'll start with that one, maybe hand it to Dr. Aflalo to talk about what she's finding as she talks in the community. Certainly with my own patients, like I said, I take care of people who have diabetes or high blood pressure, have HIV, have other conditions that are chronic that put them at more risk for having a more severe experience with COVID. Thank goodness Keisha did well, but I also cover in the hospital at Palomar sometimes, and we hear that same story, oh, I just had a cold. It made me think, to remind everybody that, we still want you to get tested. There's still great testing access out there. So please do use that. We also have new great treatment for people who have COVID, including the monoclonal antibody that if it's good enough for the president, it's good enough for you. And we certainly want people to get all of those treatments. So we want people to get tested and treated for COVID if they have it. But as far as the patients who have other conditions, what I say to them is these conditions mean that you might have a worse case. You might be like Keisha in the beginning and then end up in the hospital the second week. And so those are people that we want to have the protection. Sometimes my patients ask me, well, is it safe for me to get the vaccine because I have a weakened immune system or I have another medical condition? And I say, that's the reason you should get the vaccine, because if you get COVID, you might have it worse than somebody who doesn't have your conditions. The main consideration for people who have another medical condition or have an immunosuppressing condition, like say HIV or other cancers or things like that, is that they might not have as strong an immune response as someone else. Now, that doesn't mean they shouldn't get it. That means they should get it. But I kind of say it's like a seatbelt. It's like, you know, the vaccine is giving you a seatbelt, it's protecting you. Maybe if you don't have as strong an immune system, your seatbelt won't be as strong, but it's still there. You still want it. So I strongly recommend it. And it was, those groups were included in the clinical trials. So when this vaccine went through all those clinical trials that the FDA does, phase 1, phase 2, phase 3, none of those were skipped for these vaccines. And they did include people who had other medical conditions like hypertension, like HIV, like other problems that might make them more at risk for getting severe COVID. So the short answer is yes, we do recommend it for those groups. I don't know if Dr. Aflalo or Dr. Soon, if you have any other things to add.
I'll just chime in real quickly. I usually tell people the more chronic medical conditions they have, the more likely they need to get it, which means that there's a reason why we started with our seniors, and then we're going to go now with people with comorbidities or chronic medical conditions, because they are the highest risk for landing up in a hospital, possibly in ICU and ventilation, and possibly death. So there's a reason why strategically we're letting the younger, healthier people stay till the end, is because they're less likely to get as sick and or die than the people that have chronic conditions. So by all means, sickle cell should definitely be in line to get a vaccine.
Totally agree. I just added in the chat the link. The CDC explicitly calls out sickle cell disease and says this is an underlying condition that's associated with worse outcomes if you get COVID. So all the reasons that they mentioned earlier, they should be prioritized for vaccines.
Thank you. I want to come back to you, Dr. Aflalo, because when you were talking about the different groups that were eligible for the vaccine, this is more of an equitable question. When you think about our African-American communities, our Latino communities that are at the highest risk, but they are not able to get into the first year of the vaccine, regardless of their age, regardless of their community, regardless of disease, how are we working with that? And that question might also be for you, Dr. Sion, within the county.
Well, I do know that the county is trying to strategically keep health equity in mind. So there's certain places where they're carving out a percentage or a number of vaccine appointments for specifically areas in the community that are hardest hit with the virus. So South Bay and Southeast San Diego and some other places, East County, that they have 2-on-1 to help our seniors who may not have, internet access and are therefore not eligible or able to get on a computer and beat the rest of the San Diego County to fight for a vaccine appointment. But we have some areas carved out. And I have been involved with San Diego Black Nurses Association, and now I'm partnering with UCSD to vaccinate the Black and Brown community. So I'm keeping those appointments off the grid so that all the other communities in the North County can't get access to it, because they seem to have a way of getting on the computer, getting them. And the community, it may be in our community, but we'll see everyone else in the community getting the vaccines other than people that look like us. So there's a reason why I'm deliberately keeping those appointments off the grid, so we can, within our community, by word of mouth, go ahead and get our people vaccinated, because we are the ones that are, number one, the lowest percentage of vaccinations, but the highest percentage on the other end of illness and death. So we have to strategically work the system, right? And I'm very good at that. So we will just keep our appointments off the grid and by word of mouth, which we're very good at, getting the word out and getting people vaccinated. And I do want to say one other thing compared to what in terms of why the Black and Brown community is at high risk. We also are the ones that are out there doing the work. So there's some people that are able to work, at home and do the distance learning and all that other stuff. But there are also people that have to work. The ones that are delivering our mail, putting the groceries on the shelves and doing all the things, working at a few of the restaurants and things like that. We are the frontline workers, the essential workers. So we are much higher risk for exposure. And then we also have the underlying medical condition. So it's quite like a double whammy that we're most likely to get infected, and also bring it home to a loved one, a grandmother or someone, because we live in compacted households, multi-generational. And so we're just a ticking time bomb, and we just need to get those vaccines out to those communities, but continue to require and recommend that they get tested often.
Absolutely. I just want to add that, we are, purposely putting vaccination sites in areas of highest needs for that reason. But of course, like Dr. Aflalo said, that doesn't mean that other people from other communities can't come into those reasons. So we are, and we've been piloting this program called Project Save. And I know, Dr. Aldous, you've referred people to that, so you can talk about your personal experience, and maybe Dr. Aflalo too. And so this is a way that we use our community health worker contracts and our contracts with folks like the Multicultural Health Foundation to get people who need that extra support and assistance, to spots that we are just reserving for them. And so we're kind of trying to minimize the barriers. We're trying to, we've worked with MTS to get free transportation to these sites, et cetera. But in addition to county testing, vaccine sites, of course, there's our partners. We know that our community providers, we know that other groups like Black Nurses Association, Hispanic Nurses Association, Champions for Health, that they have really trusted relationships with a lot of people, and then they can hopefully influence and vaccinate people, Black and brown communities specifically, at higher rates than maybe some of our sites or other providers. I did also want to say, in addition to structurally putting the sites at certain locations and being systematic about that, we also have to overcompensate, right? We have to overcompensate for whether we know it's about hesitancy, English speaking, or geographical needs, and things like that. So we have to be creative. We have to, for example, use CAL FIRE in the backcountry to get to certain people. We have to make sure we're speaking other languages. We have to make sure we're addressing hesitancy proactively. And so all of these kind of efforts at once and together really will help us get to an equitable distribution. And I do want to emphasize what Dr. Aflalo said, that as we are opening up to these other essential services and sectors, we have to make sure that everyone is aware that they're even eligible. People who are, working in the security field, if you're a security guard for, a company, a business, you're probably more likely to be Black and brown, at least from when I walk around, to businesses. And so they need to know that starting Saturday, they're eligible, right? And then the other thing I'd say is that there's also some pharmacies and 25 in our community, specifically CVS, Rite Aid, and Walgreens, that also are getting vaccines directly from the federal government. And the ones that are getting those are ones that are in more affected parts of our community. So that's another strategy to help make sure access is not an issue. But access, like Dr. Aflalo said, is just one of the solutions or parts of the solution.
So where would people find information when you're talking about the CVS and Walgreens? I know anytime I call CVS for my prescription, the first thing that they say on the recording is, if you're calling about the vaccine, we don't have it. But now I'm hearing that they might. So how do people find out where, if it's in their community, where can they go? That's more than just perhaps looking on a website.
I'll add to some of that. Word of mouth is always a really good thing. You'd be surprised. Even at my own church, this past Sunday, I attend the City of Hope International. And this past Sunday, we actually were giving out vaccines to the elder population and the high risk. I found out through somebody else. It's my church. This person does not attend my church. They knew about it and told me, and I was like, well, wait, this is my church. I didn't even know. And that's partly my fault, because I hadn't recently looked at our word on the street, which advertises those things. But I think word of mouth is really important. Also paying attention to the resources that you do have, case in point, with my church, we have a weekly that goes out that tells you about the different activities. So if we are targeting and trying to make sure that there's access to, populations that are more at risk or in Black and brown communities, churches are always a good resource for that type of information, because a lot of things come through that, because most people trust their pastors. Another thing, again, back to word of mouth, I have a girlfriend who works for UCSD, and she told me she works there, so she was already able to get the vaccine, but they were doing a volunteer initiative. So if you come out to Petco Park and work a shift in helping, disseminate the vaccine or in whatever capacity that you volunteer. At the end of the night, once everybody who is there, who is an elder, or who falls into the higher risk category, gets their vaccine, then the volunteers are able to get them. So like, even if you're a younger person and you don't fall into that high risk category, part of your pay, for lack of a better adjective, for participating and volunteering would be actually to get the vaccine early. But you have to sign up, you have to do a background check. There are a lot of things involved in that, of course, because UCSD also has to protect themselves. But that's another avenue as well for people that a lot of people don't know about. I certainly didn't.
Can I just piggyback real quick, Nettie, before you jump in? Keisha, I just want to let you know the reason why City of Hope International had it and you didn't get a chance to find out is because that opportunity dropped in my lap 2 days before. So it took me 2 days to round up, but we vaccinated 240 people that day. It didn't help that our pastor went on KUSI and talked about it. So we had gobs of people that came out, and we actually had to turn away about 60 people. But I will say the other piece of that is, so we did get the majority of our church and our community and their caregivers and everything. But I will say that the volunteers, which didn't look like us, end up getting vaccinated at the end of the day, which I was a little uncomfortable with, because we turned away Black and brown people to vaccinate people that didn't look like us, because sometimes they know how to work the system. So if they know they're going to get vaccinated, if they volunteer, there should be probably something where they need to do a few shifts
Right.
to be able to get it, to jump the line in front of the Black and brown people. So I just learned that from here on out, I'm getting Black and brown volunteers so that I can make sure that they're vaccinated. So I just want to let you know, it wasn't an oversight. It was just an opportunity that dropped in our lap like the Thursday, and we got it pulled together by Sunday.
Oh, thank you
Go
for
ahead,
that. I
Maddie.
thought I got caught slipping myself and not checking, because Mona actually told me about it. So thank you.
I wanted to just add on this topic, we're talking about, there's so many different layers that have to happen. And so, on the county task force, I will say that there's a lot of focus on ensuring that the doses get where they need to get. And how can we carve out that Project SAVE? It carves out doses for certain zip codes that are most impacted. So that means that you're reserving spots for people who are the most impacted. But there has to be so many different facets to the approach, right? Some people are very motivated, they're clicking on their computers. Other people, they're busy working. Sometimes I'm so crazy about the vaccine that I'm just calling my patients and I'm pushing it all over them. And they're like, well, I can't go today. I have to go to work. They have other priorities. And so we have to also remember that, there's a pool of people in the county who are very motivated and they're jumping on top of things. But there's a lot of people who are probably most at risk, but they also have a lot of priorities they got to face, right? They're dealing with work, they're dealing with childcare, they're taking care of other people all the time. And they're not necessarily saying, let me drop everything and log in and push myself to the front of the COVID vaccine line. So we have to reserve that and reach out and make it easy. And then I think we also can't forget that there's people who who feel uncomfortable or nervous right now. And I was wanting to thank Renique for talking about the vaccine experience. And, really, we need these trusted messengers to be out there telling people, yeah, it is important that you get vaccinated. Yeah, go ahead and use that resource that Dr. Aflalo is bringing to the community. Yeah, get your questions answered. So I think as I've listened and been involved in this work for a long time, there's a lot of layers, and it's not just the access. It's also really making sure that people are, we meet people where they're at and reach them and get them the right message that they need and make a system that works for them too.
Thank you. Renique, I do want to turn to you and ask you, what motivated you to get the vaccine and how did your family feel about it?
So I decided to get the vaccine because, one, with the whole COVID testing and all, I'm out there with the people testing them. So unlike the testing sites like Tubman Chavez and different sites like that, I'm with a group of people that goes into the nursing homes and test those people. So I'm in there with the nursing homes or senior livings, testing them. So I'm a little more closer than people at Tubman Chavez are with people. And these people, some of them have already tested positive, or it's a proactive or epi request. So I've seen Dr. Sayan's name a few times at work. So that's why I decided to get it. My mom has gotten the COVID vaccine. She's gotten both doses already because she works in the hospital, and she encouraged me to get it also. So it's like, I think that it's good to get it. My great aunt actually passed away from COVID. So I'm like, I know that if she was, look, I know if she was able to get the vaccine, she would have gotten it, but it actually did not come out until she was in the hospital with it. So she was not able to get the vaccine. So I know if she was able to get it, she would have gotten it. And I'm like, let me do something, let me do my part on getting the vaccine and taking the next step.
Thank you, Rick. And so sorry for your loss and your family's loss, and appreciate the work that you are doing going into the nursing homes, and that's a lot. I want to shift it back a little bit too, to just for us to think about what are some, like all of you working in the communities, working with patients, what are some of the myths that you can help to dispel when it comes to this vaccine that is really keeping people in our community? Not only do they not have access, but even if they did, they may not want to go get the vaccine.
There's so many.
know.
I'm sure all of us are.
The microchip, the vaccine has a microchip in it.
We're all trying to think of our favorite myth to debunk. So we could certainly, maybe each of us give you the one that we hear, and then answer any of them also. I was talking to one of my patients in Southeast the other day, and we were saying it sort of feels like the community gets hit the worst, and then somehow all these myths also seem to get pushed on the community too. And I'm not a paranoid person, but I sort of feel like, why are people coming out and telling these things and making it harder on the community that already is being hit the hardest? So I find the myths to be difficult because it clouds what's really important, which is people have real questions about vaccines. They should be talking to their doctors and getting the information they need. And then there's these other things that come down, like a microchip, and that one I'm like, I don't even know how you get a microchip into the little needle. So I think that we want to sort of redirect folks to say, caution what you look at, caution what you see on the internet, right? Understand that there's some misinformation out there trying to sort of keep you from getting what you deserve and need. And so to ask your doctor, like, really what's going on there. So the microchip one is one where I say, when I actually talk to my patient, I say, how do you think that would really work? We can't really get a microchip just through a needle. So that's probably my favorite one, but I do hear quite a few other ones that I think are important to touch on.
I think the biggest concern for the group of people I see, and there are a lot of myths, and there is disinformation shared and misinformation shared on our social media, but we don't do ourselves any justice by continuing to forward it on to other people. So I try to tell people, please don't send that. There's no truth to it. Do some research, and if you want to send a link with a CDC or something else, or a county website. But I think the most I hear about things are they're concerned about the rush. They feel like it was rushed. And it's like, well, why all of a sudden now they want us to get it? And, they're never here in our community, but they're also concerned about all of a sudden now there's a vaccine and now they want to push it on us. So why us? Why now? And it's really about letting them understand that it's really a matter of life and death. You either, decide when you're ready to be vaccinated and have a chance of living, or Russian roulette with that bullet that comes out. It may very well be that there's a likelihood you're going to get infected, and most likely you're going to get very sick and possibly die. And people, if your family hasn't been affected, someone around you that has had a loss in the family. And so think about that. And usually, I've been able to convince people that were not interested and had hesitancy, just giving them time, entering in their space, answering their questions, and making them feel comfortable about it. And then they actually have gone ahead and gotten the vaccine. So I think it's just a matter of, decreasing the fears that they have, reassuring them that things are actually fine, letting them know that you yourself have received it, and I haven't grown an extra ear and a horn and all that. And so they actually do respect us. We are all trusted messengers. And I think that's where our voice needs to be, centered.
I wanted to just touch on the rush thing, because that's an important one. Was it rushed? And what I always tell people is it went faster than the usual process. And the reason was they threw money at the problem, right? So this was an issue, unlike so many other medical problems, especially problems that disproportionately affect minorities, where we have not put money on the problem. In this particular case, because it was a national emergency, a ton of money was thrown at the problem. And when you throw a lot of money at a problem, you can do even real science with all the stages. You can do it a lot faster. So they didn't skip any stages. We do science in phase 1, phase 2, and phase 3. This is true for all drugs and vaccines that are approved. They go through a safety stage, they go through does it work stage, and then they test it on more people, and then they give it to people. But usually that takes some time, right? They test it, and then if it's good, then they take their time to plan the next stage. They don't want to put money into the third stage if the second stage isn't going to work. In this case, they just threw the money at all the stages simultaneously so that when phase 1 was done and it looked like it was good, they were ready to do phase 2 right away instead of waiting a couple months to, and same thing with phase 3. And then when phase 3 showed that they worked, which these vaccines are highly effective, as you said in your introduction, they had already been making them. And that again is they put the money into making them so they could put them out right away. So when we say rushed, it's more that they just took what the usual timeline and cut out all the extra fat and made it happen faster. And I think that's really important distinction to understand.
Absolutely.
I have a question. Oh, go right ahead, Keisha.
Sorry, I actually wanted to add to what Dr. Aldis was saying too, because I think people, me working in the clinical research space, like we hear all the time, like, oh, it just came out of nowhere. Where did this vaccine come from? It's like, actually, no, it didn't come from out of nowhere. We've had previous experience with SARS and MERS and other vaccine studies. So as Dr. Aldis said, we did trim the fat because typical, what we call bench to bedside is 17 years from the time a vaccine is created to the time it's introduced to the market. Truth be told, that's very antiquated. It shouldn't take that long with the technology that we have. It just shouldn't, right? But as she stated, there are several phases. Phase 0 is like, okay, well, how is this going to process in the body? Phase 1 and 2 are basically safety and efficacy. Is it going to work? Is it safe, right? Phase 3, you're kind of comparing like the vaccine to what the standard of care may be. So typically, what have we used to treat things with before? How does this vaccine compare, against that? And then phase 4 is like FDA approval, and then like testing it again to get additional data. So as Dr. Aldis stated, like there was so much money thrown at it. And in some cases, like we had no standard of care for this. We had some idea, but like this pandemic, just the rate at which it spread was like, we hadn't seen anything like this before. So of course, at this point in the clinical research area and medically as well, all hands are on deck. So it's not like it just came from out of nowhere or people are just cutting corners and injecting anything into us. There have been years and years and years of studies to similar vaccines. And then we took the information that we already knew and we just, developed it even further.
I have a couple questions about that because I know in my research with this, not only did they throw money at it, but they also had thousands more people participating in the trials than typical vaccines. I mean, my understanding is there was like 30 to 40,000 people in each trial when they may have been 10 to 20,000. So that is one aspect of it. But then the second thing to me, which is speaking to the myth, is did they have Black people in these trials? Because everybody's different. And if they only had white people, how do we know it worked with us?
So it's tough, right? This is kind of one of those cases where you're darned if you do, you're darned if you don't. Historically, African Americans don't participate in clinical trials for a number of reasons, right? Whether it's Tuskegee, whether it's Henrietta Lacks, whether they have just conditions that don't allow them to, whether they just don't trust science. And people will give you very valid excuses like, hey, you don't buy a phone when it first comes out, do you? You wait till a little while till they work all the kinks out. Like people have all these valid reasons. I'm not knocking anybody's reasoning because it really is a personal choice, right? It's if whether you feel comfortable with it. But the problem is if we don't participate, then the things that are generated don't necessarily always benefit us. Specifically, like in my area, if you're in genomics or genetics, like if you don't participate in clinical trials, then when there's a variant that comes up and it's an unknown variant, because it hasn't been tested in African Americans, most populations that it applies to are European because they actually come and participate. So it's one of those things where it's like, the cart before the horse. It's a challenge. But if we don't have people to participate, then there's no population for them to study to see what's different. And as Dr. Aldis and I think Dr. Flalo mentioned too, there are tons of people who participated in this trial. Again, it's a life and death situation in a lot of cases, right? So you have people with pre-existing conditions, you have people from all walks of life participating, but a lot of times historically, you won't see us participating in clinical trials for any number of reasons.
These particular
largely,
studies did make a big effort, and I mean, Keisha's 100%, she just said it perfectly. But these studies, I will say that they have made a big effort. I believe it was, I want to say 10%, but I could be wrong. But it, unlike some other studies, there was a real sort of allocated, like, we want to have this much representation, and there was a lot of effort even blocking and then continuing to enroll only minorities to try to get those numbers up. So I think it was 10%, but I'm not sure. But definitely the clinical trials did include as many underrepresented minorities as they could get, because they wanted to be able to say that all groups were included.
and it's sad though, because that very same reason where they were attempting to try to engage Black and Brown communities like they never had before, also raised eyebrows in Black and Brown communities, like, oh, why are they trying to give us the vaccine? Is it forced sterilization? Are they trying to, like, people have been listening to Lord have mercy, Bill and Melinda Gates talking about the population is too crowded and we need to, like, some of the stuff is just absurd. But it's again, you're darned if you do, you're darned if you don't, because if we weren't targeted, our communities would probably have something to say about that as well. Well, nobody's reaching out to us for us to get the vaccine. So, it's tough.
And I just want to add that, because they took this monumental effort to try to get and be as inclusive as possible, even if that, even if it could always be better, because they had more, we are able to confidently say that the data showed that the effectiveness was similar across all race ethnicities, as well as age groups, by the way. And that's also true, generally speaking, when you look at this upcoming vaccine, Johnson & Johnson.
Mhm. Thank you. I want to ask you to continue our conversation too. What are some of the myths that you have heard, Dr. Sion, that you can help us dispel right now?
I think everyone else spoke about them really well. I think the biggest thing and the biggest shout out I want to give is really the messaging from blackcovidfactssd.org that really trust and verify, right? We know, like, we are all smart people. We all have that gut, that we can check. And if someone tells you something that sounds a little off and you're not sure, just, listen to them, hear them out, but verify that. Go to, a trusted organization, go to a trusted professional, medical professional, et cetera, and just make sure that you understand what you're hearing and see if that's true or not, so you can make the most informed decision in terms of whether you choose to get the vaccine or not when it is your turn.
I thought of another myth that I think is important that we touch on sometime in this meeting, which is that can I get COVID from the vaccine? We touched on it earlier when talking about how the vaccine is made, but I think, there are some vaccines. Remember, I just said in the beginning that there's a lot of different ways to introduce the virus or a bacteria to your body and train your body to have a response to it. And there are some vaccines that introduce kind of like a weakened, like a weak form of the virus to your body. And I think that because there are some vaccines like that, there's been some question of like, well, is this vaccine like that? Am I being injected with the COVID vaccine virus? And I think that's a really important question, right? What's in this shot? I wouldn't want someone to put something in my arm I didn't know what's in it. It's really important that none of the vaccines that we have right now are what's called live attenuated. So they're not a live COVID virus that's being put into you. All of them right now, and then upcoming the Johnson & Johnson, work by giving your body a little piece of messenger material and allowing your body to make a piece of the protein from the COVID virus. And then that teaches your body what the COVID virus looks like. And then when the COVID virus comes in your body later, you're ready to defend yourself. So I think that's a myth, but it's not one of those like internet myths. It's a reasonable question, right? Is this one of those vaccines that could give me a virus? And the answer is that this particular vaccine does not work that way. So you cannot get COVID-19 from the vaccine. The vaccine itself is these two that are already available, Moderna and Pfizer, are messenger RNA. So that's a little piece of a template that your body uses to make proteins. It's very unstable, which is why you have to like keep it in the freezer and all that stuff. And so when we give it to you, it gets into your cell and you make the protein and then it's gone within a very short time. So it doesn't get integrated into your body and stay around forever. It's over pretty quick. So those are some, I think that one's pretty common that I hear.
Thank you. One other one that I think would be important to address. I know here in San Diego, we saw that there were folks who had allergic reactions to some of the vaccines. And so then it brings up this whole notion of vaccine related deaths and are the numbers really accurate? And maybe I'll just stay home and keep a mask on and not get the vaccine. Can you help dispel what some of that might be?
I can start and please others chime in, but really, I mean, these are safe and effective vaccines, right? But they can have effects, as Nettie said, or Dr. Aldous said, right? They can have effects or what's called side effects. In the rare circumstances, there are individuals who've had what's called severe allergic reactions or anaphylaxis. When they looked at the data through the 18th of January, since December, and this was, I believe, like 17 million doses that were administered, there was about 70 plus people who had those severe allergic reactions. All of them were fine eventually, and they sought medical treatment, etc. And what I would say is that there's a few things we could learn from that, right? Is that one, we screen, and every provider who's giving vaccines has to screen for certain kind of risk factors, reasons why we may want to monitor you, especially more than the average person. So the usual person, we monitor regardless for 15 minutes. That's standard for any vaccine, even if it doesn't always happen. That should have happened when you got your flu shot last year at the pharmacy, et cetera, right? We're supposed to monitor you for 15 minutes. And so some people, if they have a history of allergic reactions to other things, then we will monitor them for an extra 15 minutes. And then not only that, but all of the sites and every medical provider who's giving vaccines has to have certain things to be able to handle any immediate allergic reactions. But again, they're very rare. I'm talking about 1 in 200,000 for Pfizer from that earlier data, or even rarer for the Moderna, right? But so these are rare, but if they do happen, all the sites are equipped. So really the benefit far outweighs the risk when you think about, right, as a society, how can we get back to normal? We know that businesses, our economies, our schools sometimes are closed, things like that. And so one of the best ways, in addition to everything else we know we should be and have been doing, and all the small and sacrifices you all have been making, is to also get vaccinated, right? To help your community get back to normal. And your community is affected more than some other communities. So you arguably need that vaccine even more.
And just because you're vaccinated doesn't mean you should not wear a mask.
Agree. Yeah. So, there's some kind of information we're still learning about the vaccine. And one of those questions, we think, and we have hints of information suggesting that vaccines prevent transmission of the disease, but we don't know for sure that you can't be a silent spreader. So while that science is still being worked out, it's important to still continue the usual things. The other thing is that these vaccines, as mentioned, they're over 94% effective, but they're not 100%, right? So we want to make sure that we're doing everything we can to prevent disease transmission and lower those case rates, get back to normal as soon as we can.
I'm going to just say that Dr. Sion gave a perfect public health answer, and that is the answer that I give at my health center because I'm in charge of infection control. So everyone has to wear their mask and keep it all going even while being vaccinated. But I do think we got to be real a little bit. It's nice to be vaccinated. I don't know if Renique wants to chime in on that, but it is a feeling of protection. It feels good to know that you have that protection, and the vaccines are highly effective. So obviously we want everyone to make sure most people in the county haven't had their vaccine yet. So we still need to protect them and use our mask and use our measures. But I feel like because we say that so much, so maybe people think, well, then why would I even bother getting vaccinated if I still have to wear my mask and I can't do anything? But you know what? It does make a difference. It makes a huge difference to your own risk, your own chance of being in the hospital, and it makes a huge difference to you protecting your community. So I absolutely 100% agree with Dr. Sayon, and I absolutely say that, but I also want people to know that being vaccinated does make a difference. It's not just, well, I got to wear my mask, so why bother? I think that's important.
And to your point, actually, the CDC is looking at making and kind of revising their guidance for fully vaccinated people, right? So that maybe, you'll be allowed to, or it'll be more kind of kosher, if you will, to hang out with certain people who are in a group of people who are all fully vaccinated, right? So that guidance is being worked out, but we know that because there's still high rates of COVID, we're still in the purple tier and all that stuff, that's why it's still important to follow those kind of the usual public health kind of interventions that we know work. I would say also that, to Dr. Aldis's point, that the CDC did say that you do not have to quarantine after a close exposure to someone with, if you were a close contact to someone with known COVID virus, and you were, within 6 feet for 15 or more minutes, you don't have to quarantine if you were fully vaccinated within the last 3 months. So there is slowly that guidance changing over time, but we just want to tread cautious and slowly, just given the high case rates we still have.
I also wanted to add one little small point, sorry, about the not the contraindications, but just the adverse events. Even though it's really rare for COVID, or when you look at the actual number of people who've been vaccinated, I do want to share that it's not rare for there to be an adverse event or a side effect to a vaccine. That is common. I just think that COVID gets a lot of attention for obvious reasons right now, because it's such a prevailing headline. But honestly, for everyone who is listening, an adverse event is not an unusual thing. Almost any medication can cause it, right? It just depends on the person. So please don't allow that to deter you, or thinking that you may or may not. It is way more common than most people realize. I just think there's a heightened awareness to it right now because of COVID.
I want to thank you for bringing that up, because I think when we see patients, I'm sure Dr. Aflalo is the same, they kind of say, well, I'm worried about this one little tiny thing. And I think, look at all the other things you do that have way more risk: getting in your car, taking these other pills you take, taking all this other stuff you take. But that one little tiny thing, and I'm not discounting people's concerns, but I do think, as Keisha said, really putting it into perspective of like the risks are extremely low compared to a lot of other things that you don't even think twice about because they're not maybe new or you hadn't thought about it.
And I'd like to just tell them, I don't talk about side effects. I tell them there are expected effects that are going to take place with this virus, so this vaccine. And so if you don't get them, that's a wonderful thing. But these are expected. These particular list of things are expected to come from the vaccine. So don't be surprised about them. And so that kind of lowers the expectation that if they get the body aches and all that other stuff, the nausea, vomiting, that is actually one of the expected symptoms that will come with the vaccine.
Thank you. One last question, it's coming from our audience. Dr. Aldis, as you were talking about the way that the vaccines were working, is the Johnson & Johnson vaccine, does that work similarly, since we know that that's my understanding is it's just the 1 shot versus the 2 shot?
Yeah, and I, Dr. Sion actually just presented some data to me at a meeting a couple hours previous, so he might want to chime in. But yeah, so I'm really excited about the Johnson & Johnson vaccine because it's 1 shot and it doesn't require all this fancy refrigeration. It works very well. I think there's a lot of, it kind of like Keisha was just talking about with the side effects, the media likes to talk about stuff. They're like, oh, it's only this effective or this effective, but it's really actually very effective. And it's really apples to oranges to compare them, because the Pfizer and Moderna were tested over the summer, and the Johnson & Johnson was tested later in the pandemic. So that's a little plug for the new vaccine coming. It's going to be 1 dose, which is going to be great. I mentioned that the 2 vaccines we have, the way they work is they take a little piece of messenger RNA, which is not very stable. They give it to your body, and your body reads it and produces the protein. So the way that the Johnson & Johnson and that particular type of vaccine, which again is old technology, which is pretty cool, that as Keisha mentioned, this pipeline of research is now bearing fruit for us to be able to use it and have a vaccine against COVID. So anyway, that one takes a piece of DNA, which is more stable, which is why it doesn't have to be, that refrigeration, turns it into that messenger, and then you produce the protein. So kind of similar idea, but just 1 step backwards. And so that's what's coming down the pike, and it will be 1 dose, which I also think is really nice. When I had to wait to get my 2nd shot, and then I'm not protected until 2 weeks after my 2nd shot. And I thought, oh, how nice it would be to just get 1 shot and 2 weeks later, like, you're done. Dr. Sion, you have anything else to add to that?
Sure. I just want to say that this type of technology was even used as recently as during the Ebola outbreak. This type of vaccine, it's called a viral vector vaccine. It uses adenovirus. It's a weakened, it's a non-replicating adenovirus. It's just another type of virus just to hold the organization. I think of it like FedEx or something. It just carries that DNA that Dr. Aldis was talking about to your body and to your cells so it could do what it needs to do. And so it uses that mechanism. That's one of the main differences, but this is a mechanism or a type of vaccine that's been around very long. It's been studied since the 1970s, and it's used in a lot of like vaccines for cows, believe it or not, and for other diseases and things like that. And then most recently Ebola, and it helped really tame that Ebola outbreak in Africa just as recently as last year, you know, the most recent outbreak.
Last question, and I'm going to ask, we can put up the poll question as I'm asking this. It went up, the first one went up and it showed about, I think 44 people said that they already had the vaccine. So that's wonderful. But the question that I have for our panelists, is it going to be like the flu vaccine where we have to get it every year, or is it just this one and done and then we're protected at least until the next situation occurs?
Nobody knows the answer to that question, as far as I know. There are, I think, probably people either on this call or elsewhere who could speculate. It's probably going to be a booster situation or something like the flu, but no idea how long, because we haven't had enough time to see how long does protection last. And so these studies, you know, the studies that had, I was going to say, like my dad said, well, I don't want to be first. And I'm like, well, you're not first, because 30,000 people were in the trials and now we've given 1 million doses. So all these people that have now gone already or have gone first, we need to follow them and see now what happens next. And then that will help us know what's going to be needed for boosters, what's going to be needed when, you know, maybe a new kind of COVID that's kind of similar comes around. Do we need to create a different kind of booster for that? You'll hear about that, you know, when they talk about these variants. So I imagine that, yes, there will be some boosting required. But at the moment, we're trying to get out of this fire first and then see what happens. I don't know if anyone has a crystal ball.
I don't have a crystal ball, but I agree with you. I have a funny feeling with there's apparently thousands of variants out there. They're just not all named. So we know, we hear about the Brazil and the South African and the UK or the B117. But the point is that as long as the virus is around, it's going to continue to mutate. Its job is to stay alive. And if we can just separate from each other and wear a mask and not allow it to spread, then it'll have less variants, which we don't have to continue to fight off. But I have a funny feeling that it's going to continue to want to survive and thrive, that it's going to continue to mutate and have variants. So I have a funny feeling, no crystal ball, that we'll probably have boosters. And I just don't know when that is.
And I also want people to know, I think there's some people are thinking, well, it's kind of going down. Maybe it's going to go away. Maybe it'll just be over. And then we won't have to think about this. And it's not going away either, but we're learning so much more about how to live with it. And so I think we'll get to a point where we learn, you know, how to use our vaccine schedules, how to use all the technology we have, how to use our precautions to get back to normal life. And this is why I think it's so important that we don't leave Black and Brown communities behind as everybody's moving forward, right? Because we are going to all get to some kind of new normal where we can figure out how to live with this pandemic or with this virus in a non-pandemic level of spread, and get back to normal life. And we want everyone to be included in that.
Absolutely. And I would only add, same here, no crystal ball on this end either. But companies like Illumina who are sequencing and using genetic information to identify variants, I think they'll play a really important role in us learning more about the vaccine and the different strains, and what we can do moving forward. But again, it's still one of those things where it also requires participation. It requires people participating in clinical research. But even those of us who are in this community medically, clinically, we're all sitting around waiting for peer-reviewed journals from New England Journal of Medicine or just different, you know, academic journals to see what our peers are doing and what information is available for us all to kind of learn how to move forward. So it's one of these things where you're kind of building the boat while you're in it and we're figuring it out. But I certainly agree with everybody else's point that there will probably be annual boosters or something. And unfortunately for a lot of people, some people may not be able to return to work without them. So, you know, we have yet to see how any of this is going to play out.
Thank you. Thank you. And for our poll results, I don't know if it's the same people, but in the first poll, we had people that said they did not plan to. And now we have, that is 0. And we have 90% that say they plan to. So I'm hoping that that is showing the benefit of all of your voices and your expertise. Thank you so much for sharing what you have for us today. Tony?
Dr. Kimani, thank you for moderating this. You, as always, were wonderful, and you brought a lot of ideas and information out, and you are definitely a professional, and we appreciate you.
Yeah.
You know, I'll tell you just personally, when I get a chance to get a vaccination, I'm going to get it, and I want to make sure that that's clear. But I would also say that my mom, who's 90 years old, she got her vaccines like a champ. My sister, who's a nurse, she got hers, and my other sister got hers. I mean, you know, I know the Young family is taking care of business, and I'm proud of that. But I did want to say before we went to thanking everybody else that you all, I don't think as an active observer that I was tonight, watching you present, I don't think that you all really understand, maybe you do, maybe you don't understand the confidence as that we have received from you, watching people of color who are knowledgeable and smart and have experience. You helped us gain more confidence. You were inspiring to us. And I think the poll that we saw is an indication of that. But you know, the fact that we have these bright people of color that are champions for us means it means everything. And I'm almost certain that the other folks that were watching it, there are a number of people who watch this now and later on Facebook. I'm sure they'll get that same thing. So, you know, I just can't say thank you enough. We appreciate you. I'm not sure how often you hear that, but you really do make us proud, and we're thankful for you. So, and hopefully we can have you back again. You know, after the next iteration of this whole thing goes. So, again, thank you very much, Roxanne. I appreciate you, and we also want to say thank you to the County of San Diego. They are our partners here, Live Well San Diego, Health and Human Services Agency. I saw Dr. Wooten kind of hanging around for a minute, and of course she's all of our sheroes. She's there and she's a part of this. So we have partnered with the County of San Diego in the past, and we do that on a regular basis actually when it comes to our training. So we want to say thank you to our partners. Also, we have a coalition that has kind of come together to advocate for issues, including issues like this. Youth Will San Diego, BayPAC, Logan Heights Community Development Corporation, the San Diego Foundation, and the Jacobs Center are all part of our coalition of Southeast San Diego organizations, or at least based organizations that advocated for these issues for a number of years, and we're working together to make sure that that happens. Upcoming programs. So as I said before, nonprofit and small business trainings, that's what we do. Our next one is going to be February 26th. That's tomorrow, right? At 12 o'clock with Dr. Grace Baguno. And on Tuesday, March 2nd, Tuesday, March 2nd, also at 5 p.m. 4 to 5 p.m. We're gonna talk about finding your purpose. Dr. Grace is amazing. She's a professor at UCSD that has a great perspective of just this inner peace and inner work that we need to do to become grounded. Also, the next Rise Now event is going to be the virus of hate, and I'm not sure how you all would. It'll be interesting to hear, Dr. Roxanne, what some of our panelists might think about hate as a virus. That maybe we have to figure out one of these folks to be a part of that. Obviously, we know about the escalating violence in the Asian American communities, and we want to bring that to an attention and discuss it from our perspective at RISE. So that will be March 18th, and you can register at that site below. And with that, we'll finish off with our overall poll question, and it's a pretty simple one. Overall, how would you rate our event? You have, there's just 3 questions there. If you can spend a little time to answer those, that would help us as we kind of evaluate how we're doing when it comes to this work. So while you all do that, participants, we appreciate you. Again, You all make us proud. We're thankful. It brings a tear to my eye to see wonderful heroes like you speaking truth to these issues. So with that, God bless you, and you all have a wonderful day, wonderful evening.
Thank you.
Thank you.
That's okay. Going back up, thank you, Dr. Seon, for that link to the myth and fact. I have a few folks I plan to send that to.